another, and we need to ensure that they get the health care what they need, irrespective of wherever they are when they are sick. So that's a good segue to invite my next chair for the session, because Milinji is there as ACS from Maharashtra, ACS Health. And as we know, Maharashtra is the state which has done tremendously well in a lot of parameters. And within health also, I think on many things Maharashtra is doing quite well. But there are many other things in which Maharashtra is trying to further improve itself. And since Public Health Department in Maharashtra is leading all these efforts, I'm very happy that he has been able to join. So, Milinji, over to you for your remarks. Thank you.
Thank you very much, Nishanji. I first of all thank NHA for inviting me here for a very important session in this context of public health. Achieving universal health is really the most important motto that any health department should be having. I also thank Dr. Indu Bhushan for setting the context perfectly well to begin this discussion. And first, I would wholeheartedly agree with him about the investments in the health sector. In the state, we always keep debating about this, that whatever figures we look, whatever data we look, the investments in health keep hovering around 3%, 4% of the GDP or capital expenditure. And we always, when during the discussions about budget and resource allocation, we say that this is such an important sector, but what we are getting is 1% or 2%, and that's the real important point that he has raised. We know our individual lives that whatever we invest in, we get. If we invest in health, we will get health. If we invest in work, we will get rewards in work, etc., etc. So that is one of the most important things about health. Since I had the opportunity to work in various sectors of the government, including infrastructure and housing, I know this dichotomy or the rift very well. Because if you consider a metro line in Mumbai or a large rail or road corridor, they simply talk about 50,000 crores, 60,000 crores, 1 lakh crores, irrigation dam is costing 80,000 crores. All such projects, without batting an eyelid, discussions will be of this tune. What we argue that if you give us that kind of money, we can revamp our entire system within 1 year. But somehow that doesn't happen. Maybe that doesn't have a glamour. Upgrading a PHC is not as glamorous as building a metro line. Maybe that is the reason. But for whatever, especially that happens to schools also. The school department also says the same. If you give us that kind of money, our entire schools will be 5-star. But that's facts are facts, and this has been happening over the years and across the states. So that seems to be a kind of universal syndrome. And that is one of the most important points, that all of us in this room should always be fighting for more investment. Because how to spend that money, how effectively spend that money is the question that comes afterwards when we get that kind of money. So that is one very important point. Second important point, I feel that it should always be debated, that I had the chance to work as medical education secretary. Maharashtra has 2 different secretaries. One is medical education, one is public health. So I had the opportunity to work as medical education secretary some years back. And since then, that time, I am observing a fact that we have a terrible shortage of doctors. 30%, 40%, and I think most of the states might be having the similar scenario. Because we somehow don't value human resources that much. We feel that salary is a bad word, wages is a bad word, as if government's, how much expenditure is going of the government on salary is 60%, oh very bad. We are not spending on productive expenditure. But as we know, I studied chemical engineering in IIT, so I always think what is different in IIT as a brand name? Are the buildings better? No. Are the labs better? Perhaps no. Are the libraries better? Not at all. What is different? Different are teachers. Teachers are world class. Like as we remember from our school days or when we were children, the doctor used to be the fulcrum. He used to see the tongue, he used to see the nadi, he used to see the eyes and would prescribe, and prescribe very effectively. But that institution somehow we are not valuing much. We are putting that institution under the name of salaries. Salary पे पैसा जा रहा है, सरकारी लोगों के तनखे पे पैसा जा रहा है. So that is the attitude I think we have to change. We are doing lot of efforts in the government saying that don't compare apples and oranges. A doctor working in the remote areas, and again as Dr. Indubhushan said very correctly, we are not only countries within a country, but we are countries within a state. Not only that, we are countries within a district. Consider a district like Amravati in Maharashtra. 10 talukas are like perfect, but 2 talukas are so remote, so tribal, it's very difficult to reach there. So these are the countries within the districts, within the talukas. So a doctor, an expert doctor working in that field is a different ball game altogether. But this is somehow our system. We have to keep convincing them. As secretaries, we try to tell the government that don't compare the salary of a doctor, a specialist doctor working there with any other government staff on the seniority, deputy collector, collector, whatever. So this is one very important thing that we have to debate upon. Do we dilute the structure of medical? You can find anywhere, but doctors, no. Doctors, we have to really make an effort to find a good doctor. So this is one thing I think we should debate about when we are discussing universal health care. Because now we are having health and wellness centers. Again, the same issue is we have everything. We have buildings, we have medicines, we have equipments, but where is the doctor to use all that? This we are facing in a state like Maharashtra, which is supposedly a progressive state, which is a comparatively richer state. And another thing I want to point out that there are many indicators where we are good. Tamil Nadu, Kerala, Maharashtra is good in some indicators. But we have to realize that this is not necessarily because of our health system. Rather, it is in spite of our health system. Because we had a long tradition of women's education, we had a long tradition of social reforms, and that has led to all these results. We should not be patting our backs that we are good because of our health system. May not be the case. So that is one issue that we have to debate, that apart from the health system, there are various other things that we require. Like Kerala is a classic example, tremendous awareness about life and the basic human qualities. That is also one of the very important factors in the universal health care. And another important factor that Dr. Indubhushan mentioned is the NCDs. Before COVID came, we were all convinced that now the communicable disease is gone, it's past, and COVID awakened us again, that's a good thing. But we were thinking that now NCDs is the real thing, and that government of India is doing very good work in NCDs and lot of good intervention like STEMI or diagnostics, so that these diabetes, hypertension, cancer, their heart problems are getting detected in early stage, and I think we have to proactively work on that. I think that's all to begin with. I think if we ponder about, and I'm looking forward to the discussion in this session. Thank you so much.
Thank you, Milinji. I think you raised some very interesting points, and I'm very happy that you use the word investment in health and not expenditure on health. That's a very small thing, but that shows the mindset. Because in health, whatever is an investment, it leads to many more things, and that is something I think is very important. And the role of medical education and reform in medical education, which is required further. And as you very rightly said, a lot of reform took place for technical education, and that is why we have so many engineers now. But for medical education, still it's much more rigid than what it could be, and there are examples across the world where some of these reforms have taken place. And in fact, Rohit, that reminds me that next time we should also invite medical education secretaries from many states. We somehow miss it, because in many states they are different. In some states they are same, like MP, but Maharashtra they are different. So I think we should, because tertiary care is provided through medical teaching hospitals basically. So now we go to our panelists, and I think we have a very good set of panelists which will really bring out the issues from different perspective. So we have with us Aradhana Patnaik from Jharkhand cadre, who is Joint Secretary in Ministry of Health, and I think in her current capacity also she is dealing with some very important issues like drugs and all, which have huge implications out of pocket expenditure in a country like ours. But I think also because I know her for maybe 15 years when she was looking after RSBY in Jharkhand, and she was the one who actually made it happen in the scheme in a very difficult scenario that time. So I think she can draw from her experience from that time also to have some things. So, one first question I have, that you have seen how tricky it is to manage a health insurance scheme at a state level, especially in a state like Jharkhand where you don't have too many hospitals available in the private sector. Public sector hospital reform is also challenging. So, and now you have seen how PMJ is evolving. So what kind of learning or suggestion you have on based on your past experience and what you can see now?
Respected dignitaries on the dais and off the dais, ladies and gentlemen, a very good morning to all of you. I have, as Dr. Nishant said, I have had a very long association with health insurance scheme from the time 15 years ago when we had the first health insurance scheme in the entire country. That was the Rashtriya Swasthya Bima Yojana. I was spearheading the mission there in state of Jharkhand, which is my cadre. So as you all must be aware, Jharkhand is one of the most difficult states to work in. There's a lot of political instability, a lot of other issues like dealing with left-wing extremism. At present, of course, the situation is much better, but down the line of 13, 15 years ago, it was very precarious. Reaching out to villages was quite difficult. And if I'm able to recollect, at that time, though Naxalism was at its peak, during our various meetings, we could showcase Jharkhand as one of the most difficult states where RSBY could happen in spite of these challenges. A lot of tribal population, forest area, geographical challenges. In spite of that, a lot of initiatives had been taken by the state government which made it happen. As I move towards today, over the last 10-15 years, the change has happened from RSBY to PMJ. A lot of changes have happened. This scheme has done wonderfully well, and I think if I compare, the robustness of this scheme is one which is really worth mentioning. But again, I would like to focus more on the challenges, because I've recently I've spent 25 years in the state of Jharkhand, recently joined Government of India as Joint Secretary this year itself in April. And just 2 days before I was again in Jharkhand, if you are aware, we have the Ayushman Bhava campaign of Ministry of Health and Family Welfare going on in the entire country starting from 17th September, and the Pakhwada is from 17th September to 2nd October. So as Prabhari of Bihar and Jharkhand, I had visited Jharkhand, and 2-3 learnings I had during my 2 days visit. Some challenges and some very good practices also I could see myself. One, as you all are aware, if we are talking of reaching out of universal health coverage. So what do we mean by that? Sir has given a very good definition, but I'll just get down to the field ground reality. Reaching out to the last mile for me is universal health coverage. So if I'm able to reach out to the last mile, then I have actually covered everyone. Now the challenges there are, we have the most primitive tribal group, if you are aware of PVTGs, primitive and vulnerable tribal groups, who reside on hillocks which have myself traversed there, trekked 10 to 12 kilometers. You have to walk on foot, trek on foot to reach out to those villages. So you can imagine what health facilities we'll be having there. So if those we can capture. So during my visit to Jharkhand, I saw that in one of the districts for the Birhor tribes, a special campaign was organized for covering all of them under PMJ, which was really very good. The collector there could think of reaching out to the last mile. So one thing which I feel is, if we focus on these difficult areas where access is an issue, if we have PMJ cards for them also. Second was, I saw that there was lack of awareness. So they also had an awareness campaign through the tribal language, through their dialect. They had Nukkad Natak for them and had brought about awareness amongst all the Birhor tribes who were residing in those villages. So one thing I feel which is really challenging today for implementation, for reaching out to the last mile in PMJ, is to reach out to these difficult areas, and those we can do through special campaigns. That is one. The other, I attended under this Ayushman Bhava campaign, we had this Ayushman Aapke Dwar PMJ, one is the one component, but we also have health melas to be organized in health and wellness centers and CHC level, apart from various other programs of organ donation and blood donation camps. So there, while interacting I attended one of the Ayushman Bhava melas. So there was a counter of PMJ where cards were being issued to now we have the self-generated cards. But while interacting with the technical staff there, I asked, सुबह से कितने cards बन पाए? तो 100 से ज़्यादा लोग आए हैं, लेकिन अभी तक हम 10 कार्ड ही बना पाए. तो मैंने कहा क्यों, इतना समय क्यों लग रहा है? तो सर कि OTP जल्दी आता नहीं है. I remember I informed Basant Gar कि OTP का problem resolve करो. It was because of the server issue, network issue. It was raining that day. I can understand these are the challenges at the field level. At times network is very poor. So they were not getting the OTP, and continuously they were working towards getting the OTP so that they could finally register the beneficiary and give him the card. So that was one. The second which they said was that while after filling up the entire thing, say 90% data has been filled, and then there's a submit button, and at times the submit button doesn't come. So हम क्या करें? I said कि अच्छा मैं फिर वापस उसको जाके I'll work it out, and so just giving this example, I'm not trying to say that there are lots of faults. It's a very good system, but these are actually the field problems which our field people are facing. So if we can make it more user friendly, lesser of inputs to be put, and more simplified, all of the entire technical team, it's a very robust team working on it day in and day out. If we can think of some even simpler things which we can, so that at the field level where there are issues of network issues, where accessibility is a problem, if we can simplify the procedures for them, so that it can be done. Maybe then after coming back to the headquarters where there's a good access, one can upload everything, and also that is one thing which I felt I need to highlight. Rest, I think a lot of things are very good happening, but one again, there in such interior areas, even sir was talking of Maharashtra, we feel Maharashtra, Kerala are the leaders. But there also, sir was saying that in interior areas, doctors are not available. There are challenges of good hospitals also. We have empanel hospitals, but I was seeing the list, there are some very good hospitals who are not on board. How can we convince them? And this, I remember, was the challenge from RSBY days. How do we convince the good, reputed hospitals to be on board? Maybe one of the challenges which still persist is the timely payment to the hospitals. So that's why the good hospitals don't want to come on board. So how we can work towards working with these hospitals so that all these services, good services with the excellent services are provided to the poor, because the PMJ cards are for the poor people, for the poor downtrodden who don't have access to health services. While the excellent hospitals are being accessed by the rich, somehow the poor are not able to access them. So how we can integrate them with with PMJ scheme, with our health insurance scheme. And since I'm also looking after drugs in the Ministry of Drug Regulation, Food Regulation and Procurement, so there again are issues of timely procurement, and that of course will not be resolved through PMJ, but drug availability. Like again in that visit I was asking, they were saying that TB drugs ekdam shortage ho raha hai. So I promised them that in 15 days hum log will ensure that they reach. So if that is also integrated in the PMJ, you already have the beneficiaries, you have the empanel hospitals, you have the list of doctors there, the human resource, everything is there. If drugs, also availability of drugs in each of the centers, be it state, or every state has its own drug procurement system. And also at the national level for national programs, procurement is happening. So availability of all drugs in all the hospitals, if it is there in one portal, one can immediately access and get it. So that would really help improve, I think, the system. And a robust grievance redressal mechanism, especially if the beneficiary has issues, or as I gave you the small examples of OTP not coming or the server not working. So those, if we can have some self-generated system wherein immediately one gives a query and immediately it gets resolved, that would really help improve the system. I think these are my, thank you.
Thanks a lot. I think, many times when we sit in Delhi and we think about policies and all, sometimes the perspective from the ground gets missing. And I think thanks for bringing that perspective very clearly, that whatever we design, it has to happen on the ground at the end of the day, and the cutting edge is basically there. And you mentioned this OTP thing. I remember once I was also in the field and OTP was not coming and we were talking. तो बोला कि सर ये one time password नहीं, out of patience हो रहा है मेरे लिए. So yes, OTP and these kind of field level issues are very important. And how at the end of the day, we have to see how we can make life simple for the beneficiary. Whatever we do is the means. The end is that person should get healthy through a timely treatment, quality treatment, whatever it is. So, and on that note, I think I'm very happy that Ratan is here with us. He's from Kerala. So we talked about Kerala in presentations during our talk also. And we talked about the good things which have happened in Kerala in terms of the indicators and a lot of things. But at the same time, Kerala has its own set of challenges. For example, if you see the data of PMJ and even during RSPY or even before in NSSO, the hospitalization rate in Kerala is the highest in the country, always. And that reflects also in PMJ. Now, I'm not saying it's bad, but I'm saying it has implications in terms of cost, in terms of access, a lot of these things. So, for you, my question would be that Kerala is doing so well otherwise, but hospitalization rate is very high, which is leading to higher cost. And since the scheme is completely tax funded, how do you think about strategies to control the cost in a better way, try to see that the sustainability is ensured? Thank you.
It's ready, no? Thank you, Nishant. Well, to answer that question, I may have to dwell upon a little bit on why we have a high rate of hospitalization.